Yeah, hi everybody. Now we're going to continue where we left off. Apologies for the dog barkathon, but my wife's watching him now. Okay. So I was talking about the liver. Those hepatic lobules, which is really it delivers just this one big thing. Anatomically, it has three areas. And just for instance, in the hilum of the liver, you'll note that there are three major structures that are involved: the hepatic artery, which is a branch of the celiac artery. And when you get to the lobules, you have tiny arterioles and really, really tiny arteries feeding the individual lobule at each point, so to speak, of that hexagonal lobular structure. You have a branch of the portal vein. These are both ingoing. And you find this also that portal vein enters at that hilum or in that area where we begin to see the so-called the porta hepatis. And then lastly, we have an outgoing channel that is really the start of a bile duct. You have little bile ductules, and that is because the hepatic cells, the hepatocytes, which are doing all the busy work of detoxifying, processing, in the meantime, they're also producing bile, which is really which is the major function of fat digestion and absorption when we get to physiology. Plus, it contains the waste product from heme, which we'll also get to when we talk about blood and blood physiology, called bilirubin, and that also acts to color urine and feces because some of it will go into the urine, some of it will go into the feces. So there's two inputs and one output. The two inputs, to summarize: a branch of the hepatic vein, hepatic portal vein, a branch of the hepatic artery, and the output would be a branch, effectively, of the bile duct. That's what. So you have two incoming and one outgoing, and that's what you do need to remember about the liver. The pancreas, less complex. You have the external aspect of the pancreas we cover in length and endocrine because that's insulin and glucagon. The interior, the exocrine portion, and again, we see a lot of these double duty glands like ovaries and testes. It has both an endocrine and an exocrine. Exocrine just means it has ducts, and this duct is called the pancreatic duct. It opens into that duct into the interior of the pancreas with a lot of cul-de-sac like structures with mostly simple cuboidal cells, which are busy producing all of these digestive juices, to use that term, which include the proteins, as you will learn, in their inactive state we call zymogens, Zymogens. That's not on this test either. A lot of the bicarbonate, because it's going to neutralize the acidic solutions that are there, and effectively that's what we see, along with a couple. And interestingly, there are also other media, electrolytes and things like that all feed into it. So it's rather a sort of a complicated mixture of stuff that's basically going to make its way and subsequently become activated once it gets into the gut, because the activation process occurs there in the environment where the other enzymes are located that can activate these precursor enzymes. So that's what's going on with regard to the pancreas. There's not a whole lot to say about it. There's a pancreatic duct. Effectively, it joins the bile duct at what we used to call the common bile duct, because they become together, they become common. And there's a sphincter that controls it that we used to call the sphincter of Oddi, capital ODDI. Again, that's not it, but I just want you to know how important an area it is. And it enters into the duodenum. There's actually a lesser duct, somewhat distal to that, but that's not relevant for this discussion. But that's such an important area with regard to the duodenum. So all of that is things that you should be certainly very familiar with. As we bring our way along and we get into the small bowel, so we've covered, and just a quick word about the gallbladder. Basically, it's a storage vessel, a lot of chambers that are there, unfortunately, as it concentrates the bile, which is not an essential area and not an essential form, it's a non-essential tissue. What it will do occasionally, based on diet and things like that, form stones. Stones are very problematic. I'm probably going to address that a little bit more when we get to the physiological aspect of things for bile stones, and we call those gallstones. And they can get trapped in a number of places, not just in the gallbladder. They can go all the way down if they make it through and literally gets stuck in that common bile duct area and sort of back and cause fluid back up into the pancreas. There's a lot that goes on with regard to this. Pancreas is very interesting and complicated. We'll get into how important it is. So, for instance, obviously the liver, we have a lot of it, and it reproduces very, very quickly. The gallbladder, not a big deal. I mean, you can. It's better to have it, of course, but you can do without it if it becomes inflamed, irritated, filled with stones. And the pancreas, extraordinarily important tissue that we cannot do without. It's not like you can do a partial pancreas. That's why people with pancreatic cancer, it's a very, very poor prognosis. There's so many glandular tissues, and most of those cancers are glandularly based cancers and very, very difficult to treat. That sums up, and effectively, those are all the accessory structures. Everything else is pretty straightforward. You get into the small intestine. Again, remember the three areas: the duodenum, the jejunum, and the ileum. Ileum. That's where it terminates, in that ileocecal area. So that's the ileocecal valve, which is the narrowing of this. These are all the valves are all smooth muscles. They're not flaps. They just narrow enough to form a basically close off when there's not to be a passageway and open to allow relatively small amounts to go out as we go. And again, we explore more of the relationship when we get to physiology of why they open and when they open, etc. They all have the same, including the duodenum. They all have the same thing. They have the circular folds, the plica circularis, the villi, the microvilli, the brush border with all those villi, the tremendous amount of surface area that I commented on before. The small intestine, we talked about the anatomy already. Nothing really remarkable about it. It's a big part of the large intestine. The first is the cecum, the appendix coming off of it, ascending, transverse, descending, haustra or haustrum for those pocket-like large areas that are about more than twice as wide or twice as substantial as small intestine is. You might have seen a little bit of that when we looked at that fecal pig. So a lot of small intestine with the fecal pig. And then you have the tinea coli and the epiploic appendages. They're all significant structures to know because they're identifiable. And don't forget the role of when we have that weakness in the wall, which is so terribly common as people get old, called diverticuli. And you're going to know somebody in your family that has diverticulitis or diverticulosis. And I mean, and like anything else, I mean, theoretically, colons, you have a lot of colon that if you have to remove some of it, it can be removed. I'm not recommending it, but it can be removed. It's again non-essential tissue. The small intestine will take care of all of that. Let's see. I think that covers everything digestively of any importance. I mean, really everything else is physiological in nature. I think we're good. That brings us to the renal system. So the anatomy of the kidney I went over with a recorded dictation. I sent you those illustrations so you can know exactly what they are, where they're located. Kidneys are protected by the rib cage. Okay, the adrenal glands are on top of them. We'll get to that in endocrine. They're relatively small. Adrenal means adjacent to renal. Obviously, they're kidney shaped. They're not as big as you think. They're retroperitoneal. The intestinal tract lies anterior to them. That's what they are. So there's a lot of protection. There's a modest amount of fat around them that protects them as well. And they have that very unique system with the pyramids and the calyces and all of those collecting structures. So you do need to be familiar with them. That's why I think labeling that illustration will help because you'll know where everything is. The hallmark is the glomeruli, and you have two. You have the the juxtamedullary, the ones that are close to the pyramids and are only about 15% of these nephrons. And they are, you just have to go back and again look at that. That's another area that I sent to you that was there. And you have what are called cortical nephrons, which are about 85%. The nephron is the functional unit and effectively the major structural aspect of the kidney. That's where filtration occurs. The glomerulus is the main part of it for filtration. that's where you have that unique system where, as the blood vessels branch and branch and branch, effectively you come to a unique capillary bed where there's a somewhat wider afferent arterial entering and a somewhat narrower efferent arterial exiting. And there's the glomerulus. It has fenestrated capillaries, and effectively the force behind them is blood pressure related, and that's what effectively is creating the filtrate. In order to extract the filtrate, we have to have a force. The filtrate is everything but proteins and formed elements, which are white cells, red cells, and platelets. Everything else, all the plasma, 99%. I beg your pardon, that's a wrong number. So see, that's a different process when we get to, I beg your pardon, when we get to reclamation. 99% of the filtrate is reclaimed. But think of it, effectively, almost all of the liquid goes out and everything dissolved in the liquid. What's left is enough liquid to keep the proteins dissolved and to keep the formed elements within. And so the blood is relatively thick and concentrated as it makes its way through the next bed, which is the next capillary bed. So you're going from an arterial into a capillary bed and exiting by way of an arterial with the blood still oxygenated. Because to create filtrate, pressure created the force. We do not have to expend any energy. All of the oxygen carrying aspect is utilized for the process of reclaiming the important dissolved chemicals and secreting all the ones that are not necessary. And so that's where you see those capillary beds that are very interesting. The ones around the cortical nephrons are called tubular capillaries because they are deeply invested in particularly the proximal and distal convoluted tubules. That's where the vast amount of the absorption and secretion, about 2/3 of it occurs in the proximal, and then somewhat finalized in the distal. It has relatively short nephron loops, so there's not a lot of water concentration, even though it's arranged similarly with the descending limb thin and the ascending limb thicker. Descending limb water is collected or returned to the circulation. The ascending limb, the concentration is balanced out by salt removal. And we'll get to that when we get to physiology. Very complex. The ones that are interesting, the 15% that are the juxtamedullary ones, there they have the vasa recta, which means straight vessels. That's the capillary bed around those long loops of Henle that make up those pyramids, that sort of ridged area, along with the collecting ducts that collect the urine. And that's where we concentrate urine. And that's because those long loops, and we'll go over the concentration gradient and how it works. That's the physiology aspect. That's a very interesting phenomenon. It's there. And so finally, after whether it's the peritubular capillaries or the vasa recta, after all that process is done, and that's where the energy is expended to reclaim the fluids and reclaim the important dissolved matters in the filtrate, reclaim 99% of the filtrate and reclaim all the stuff that needs to be brought back in and secrete all the stuff that needs to be secreted out to basically keep the homeostatic levels of dissolved things in our bloodstream. That's what the kidney does: rinses, purifies, adjusts pH, blah blah blah, nitrogenous waste, all that good stuff. And what will happen eventually? It flows back into those capillaries. The vasa recta and the peritubular capillaries eventually form veins that form eventually the renal vein and goes directly back in the vena cava. And it takes a lot of our circulation. A quarter of our circulation at rest is so we're continuously rinsing. It's amazing. We generate between 160 to 180 liters. That's 40 to 45 quarts of filtrate. And we reclaim 99% of it. That means we basically urinate out between 1.5 liters and 2 liters on a typical daily basis. Right. And then these are the kind of things in the medical environment we count. We look for what's called high and O, input and output. We measure the fluids that go in, and a lot of times we'll measure the fluids that are out, typically for patients who are catheterized. So we'll get into more of that, so you'll know where the pyramids are located, the different distinction between cortex and medullary. You'll understand about the uniqueness of the arterial supply. When you start to collect at the part after, that's all the processing. But anatomically, once its urine has gone out of the tips of those calyces, the minors and then the majors and the renal pelvis, effectively, it doesn't require any processing. And now, what we call the urinary tract starts at the renal pelvis by way of the stem, the ureters that exit and are collected temporarily in a holding tank called the bladder, and finally released by the urethra. It doesn't matter whether it's male or female, same process that goes on. When we see kidney stones, they're mostly in the ureters. That's the area where there can be narrow and don't necessarily expand. And then it typically is where they're small enough that the tiny stones can cause problem in those sort of, if you review the anatomy, you see that fan folding. Those little nooks and crannies, stuff gets stuck. Typically, it's calcium related or blood related or infection related or uric acid related. There's lots of things that can be the core. Fancy name for core is called the nidus, Nidus. So all of that's important. Remember, this is, again, fenestrated capillaries is the watchword. The big deal, and really the anatomical nuance that's so important, are the renal arteries are so much wider because it's a high pressure filter. If you look diagrammatically at the gonadal arteries below them and the suprarenal arteries above them, they're relatively small, narrow. You see the renal arteries, they're wide, big. And that's because it's a high pressure filter. That's why it's so terribly important. We get to physiology. If you don't have a sufficient amount of blood pressure, your kidneys shut down. We have a word for that, shock. Okay. Typically we call it hypovolemic shock, because usually it means there's not enough blood volume. Someone's bleeding externally, internally, vomiting, diarrhea, all that type of stuff. So I think that's really important. Remember, the pyramids are the area where we see those long nephron loops and the collecting ducts, and you have multiple feed-ins to the collecting ducts. So it isn't just one loop per duct. I mean, all the loops, whether they're long loops or short loops, and all of the distal convoluted tubules, they all fill. You have multiple of them enter into a particular collecting duct. Remember the flow of the urine. We starts at the tip of the pyramid. We get minor to major calyx. Major calyces form the renal pelvis. The renal pelvis is the stem of it is the ureter, goes to the bladder and then to the urethra. So there's one of these, pardon the pun, flow chart, because we're talking about urinary flow. Flow charts, you can see a lot of those. And you see a lot of those in exams, particularly like MCAT or licensure type exams. Those are, they're relatively easy questions to construct, and you have an idea of what's going on. That people have at least anatomical knowledge. Don't forget the trigone, because the ureters enter in the undersurface of the bladder, and the urethra exits. That triangular area doesn't have those rugae or ridges, which are when the bladder is empty, not unlike the stomach. And that's flat areas where often we see infections. The interesting thing about the bladder is that it has a unique epithelia, particularly in the ureters and the bladder. That you have to know this. It's called transitional epithelia. Why is it so important to me? That's where my cancer was. I had TEP, a transitional epithelial 1, type 1 cancer, which measures how deeply it's gone in, so to speak. The higher the number, the worse the prognosis. If it gets into the muscle, remember the name of the muscle is called the detrusor, Detrusor. It's all smooth muscle. We don't have any voluntary control over that part of the bladder. Our voluntary control of whether to go or not to go has to do with the skeletal muscle sphincter that we control. There are other sphincters that, while it's filling and things like that, that are active. Those are internal sphincters. When they start to have excess pressure, then we have to utilize the external sphincter, and we have to release it when we're ready to go. And it's not unlike when we look at the physiology of micturition, which is urination, or defecation, which is bowel movement, are comparatively similar in that regard. So don't forget the transitional epithelia. That's really important. See, and again, how it flows from the glomerulus. Remember the Bowman's capsule. And you look at those illustrations: proximal convoluted tubule, distal convoluted tubule. Pardon. Proximal convoluted tubule, nephron loop, thin descending, thick ascending, distal convoluted tubule, collecting duct. And then effectively those collecting ducts lead to the minor calyces. The difference, why we see a different kind of, and that's why the transitional is only in that once you get into the ureters. If you're looking at the tubules, particularly because that's where the secretion and absorption, those are typically simple cuboidal. So some are more active. The proximal is more active than the distal, has more mitochondria, has microvilli for surface area. Those are all, by now you should be understanding that anatomy reflects the physiology. I think that we let enough air into the kidney. Good. Which leads us to the last units, which are the reproductive. And I know this is ongoing, and we'll surely get through it by Friday. I don't think that's a particular problem. I'll make sure that I have all the information in, because some of you are going to be taking this on Monday. So that what you really have to understand is I like those analogous structures, as I was talking about in lecture. Basically, which of these is incorrectly paired, or which one of these does not reflect, like penis and clitoris and labia majora and scrotum, which are homologous or analogous structures. And so remember, everything other than the ovaries and the testes are secondary sex organs. It's not about importance, it's about definitions. So we're not taking away from the uterus or from the epididymis. You're just secondary to the ovaries and the testes. And again, we're looking mostly in this unit at their exocrine function, meaning this duct system where the egg travels and the sperm travels, as opposed to their endocrine role, which is the production of testosterone, estrogen, and progesterone. Don't worry, we won't forget it. That's in physiology when we do the endocrine system. Just remember, in men, which we've covered, the testicles descend by way of the spermatic cord, which really is a portion of peritoneum that, and in fact, and it's a fancy name structure you don't know, called the gubernaculum, is pulling down. The testes are being pulled down by this string-like structure on both sides, one on both sides. And in that spermatic cord, we have an elaborate amount of blood vessels, a lot of veins, because remember, it's all about absorbing the heat and keeping the testes cooler for optimizing sperm production when we get back into physiology. And blood vessels, nerves, still wrapped in peritoneum, because technically it's an intra-abdominal structure. It's just in the female, it stays there. In the male, it descends. But remember, the undescended testicle is called cryptorchidism. You'll see it in a second, so I make sure I'm pronouncing it properly. And unfortunately, that's a significant underlying condition for the high correlation between that, as I commented on in lecture, in testicular cancer, which is the most common of the cancers in men 15 to 35. Okay. So all of that you should certainly remember. And so what happens with that? And again, look at the flow chart that's there. So the vas deferens travel through that spermatic cord. So remember, think of where the testes are during ejaculation. The ejaculant with the sperm in it leave the epididymis. So they start in the seminiferous tubules where they form. They are collected in the epididymis and then they mature. Once they mature, then they have the capability of swimming. They are held there until such time as an ejaculation occurs. And at that point, they travel by way of the ductus deferens or vas deferens, by way of the spermatic cord, back in to the abdominal peritoneal cavity alongside of the bladder. And then eventually they join. They're joined, and this is where we're getting to in lecture on Wednesday, because I'm dictating this on Tuesday at home. Then they're going to join along the side of the bladder with the seminiferous, not seminiferous, I beg your pardon, with the seminal glands. And the seminal glands, hence that's where we get the name semen, by the way. And the seminal glands, what they will begin to do is they will form it, they'll widen, and it'll create something that you will begin to see this extraordinary change that's going on. So we're going to follow that illustration as we had talked about previously. Okay. Hold 1 second. I just want to open up another window. Can't have too many windows when I'm doing this stuff. Oh, getting here. Bear with me for just a moment until I find what I'm looking for. I'm opening a window because I want to get I apologize for my pronunciations. I'm having a off day. We had to go out and shovel, which is no fun. I give up. I'll get there. Hold on. Sorry for creating this problem. Let me go back to the exam that I'm looking at. Thank you. So, as we move on, again, getting near. Oh, God, I was until my tongue. Ejaculatory duct. So when, oh, goodness me. So when the seminal vesicles or the seminal gland join the vas deferens almost exactly as it's about to enter the prostate and join the urethra, okay, that's where we have the ejaculatory duct. And so the ejaculatory duct is that important structure. And then what happens, the ejaculatory duct then meets within the prostate gland, as we will look at in class tomorrow on Wednesday, the whatever date, that's the 3rd. And it's going to form within the prostate with the urethra, and effectively that forms the prostatic urethra, which now is receiving the ejaculant as part of it. It goes through the membranous portion of the urethra, which is just a transition from the intra-abdominal cavity to outside of the abdominal peritoneal cavity, and effectively then it goes into the penis itself by way of the spongy urethra, that elongated portion that we see externally, and then is released by the process of ejaculation, and we'll talk about that with regard to that. Again, that's again more physiology than not. So moving on. So again, everything is a secondary sex organs. Okay, you know about the spermatic cord. So penis and clitoris, scrotum and labia majora that are there, all similar ductus deferens and the uterine or fallopian tubes. All of those are analogous or homologous structures, ovaries and testes, etc., etc. So that's important because, again, anatomically speaking, we're very much similar, as you will see in some of the illustrations as we move on for today, from either on Wednesday and on Friday. And I talked about what the peritoneum is. It's bounded by the ischial tuberosities, the coccyx, the pubic symphysis. That's effectively what it's bound by. Okay, so those 4 structures creating sort of a diamond-shaped structure, and we just have a different name for it. We call it technically it is the perineum, but in the female it's referred to most often as the vulva, vulva. Okay, let's see. Don't forget dardos and cremaster. I'm not going to ask you to differentiate. Those are the ones that are associated with the scrotum. Okay, sperm are produced in the seminiferous tubules. Don't forget the sections of the urethra. That's important. The glands, 2/3 of the semen, the vast majority of the bulk of what we call semen, of the ejaculant, comes from the seminal vesicles, and that's where it gets its name. That plays an important. There's a lot of material that act eventually from a nutrient perspective, play a significant role, that are there. And it's interesting that that's the fluid that fluoresces when they're looking forensically, let's say at a crime scene, to see if there was a sexual assault, and they're able to look for what they, oh, we better look for fluids. Well, they turn off the lights and turn on what we call a black light, which is a fluorescent light. Very common that you would have their handheld devices, and they look to see if there's signs of it, because it'll fluoresce typically with a yellowish color. You don't have to add anything to it to make it fluoresce. That are there. The prostate imparts a milky white fluid that gives the semen its characteristic color. That plays a role in activating the sperm. Okay. And don't forget the corpus, the corpus spongiosum and the corpus cavernosum, or corpora, because there's 2 of them. They're the ones on either side. The spongiosum is the one that that surrounds, and I talked about that a little bit, surrounds the urethra as it's exiting is sort of on the volar or undersurface of the penis. Remember the other things that we have in common, both the ovaries and the testes have they have a tunica vaginalis and a tunica albuginea. The vaginalis is the peritoneum that it's encased with, okay, and the albuginea, because it's white in color, is that soft, is that rather hard white kind of capsule. It's much more dense connected. We see that both in the ovaries and in testes that are there. And so when we'll look more closely at the ovary, we'll look at the follicles where the eggs are produced. We'll look at the remnant of what's called of the enclosure or of the follicle that is left once the egg has been effectively burst out of the ovary. So when the egg at the point of what we call ovulation more or less explodes out of the ovary, what's left is called the corpus. It forms a yellowish appearance called the corpus luteum, Luteu. Often with that luteum implies a yellowish color. That's what anatomists, and then really that takes the role of the placenta until the placenta forms or it deteriorates over 10 days. That's where we get the times, and that we relate that to the cycle, and it becomes what's called the corpus albicans because it turns white in color and basically dissolves and get rid of it. So we find that in the ovary. So you have the corpus luteum, you have the corpus albican, you have the follicles, you have the developing eggs themselves. Okay, and they're all part, and we'll look at that anatomically. When the egg is expelled, it's collected by the uterine tubes. They have finger-like projections called fimbriae. The fimbriae are equipped interiorly with typically columnar cells that have cilia. So they're very similar to pseudostratified ciliated columnar cells, and they produce mucus, and the ciliary action creates little eddies and currents because it's not a closed system. This is extraordinarily significant anatomically because the egg is expelled directly into the peritoneal cavity. It's it's close to, but not in direct contact with the oviducts, okay, or fallopian tubes. Any name is fine. Uterine tubes, they're all the same freaking name, same freaking thing. Okay? And what happens, that's when we get an ectopic pregnancy, which actually can occur, although fairly rare, in the abdominal peritoneal cavity. Most ectopic pregnancies occur within the tube itself. Ectopic means a pregnancy that has occurred and implanted in an area where it should not implant. Anything that is ectopic means it's not where it's supposed to be. So there's other things that are ectopic, although they're not that common in the context we have. Most we hear the word ectopic means a pregnancy, mostly in the duct, but not always. Rarely, but they can form in the abdominal peritoneal cavity. So those mucus and the ciliated cells create those eddies and currents that effectively sweep that ovulated egg into the tubes on its journey to fertilization, which occurs in the tube itself, but then carried on in implantation is typically within the uterus, almost always within the uterus. So we'll take a look at all of those cells, all of those things that are there as well. The uterus has a dome area, just like the stomach. It's called the fundus. It has a body where most of the time is where the implantation occurs. The body is where the vast majority of the lining that is sloughed during menstruation. It's got two layers, the stratum basalis and the stratum vaginalis. Beg your pardon, stratum basalis and the stratum functionalis. And what's interesting about that, the basalis is always there. It's the functionalis that's as part of the menstrual cycle that expands because it is getting prepared during the menstrual cycle. It starts right away after the menstrual cycle starts with menstruation. And we're going to go over this in physiology. And then after about 4 or 5 days, it starts to reform this layer we call the functionalis. It's all in preparation for implantation. It reaches its initial stage at ovulation, and then you'll see After ovulation, it's all about forming and enlarging and forming glandular structures which are designed to receive the egg. If the egg is not implanted, or not fertilized, but doesn't become implanted, then effectively it starts to deteriorate because that's that 10-day period. And your body sends signals to that corpus luteum and say, hey, no implantation, you're done. See you later. It's a very intricate system. So you have the fundus, you have the body itself, you have the outlet area leads into the cervix, a neck-like structure. That's what cervix means. And then the outgoing portion of the cervix leads into the vagina. And from there, outside. And that's, we call that the copulatory organ, like the penis in the male and the vagina in the female. So, and again, just like the bladder, this is smooth muscle. So all this is no combinations, has a very unique blood supply coming from the uterine artery. The uterine arteries and the ovarian arteries come off directly off, just like the gonadal arteries, which they are in the male. They go either go to the ovary or in the male to the testes. In the female, what happens is there's a separate artery that services the uterus and the one that's involved in menstruation. The anatomy is really critical to understand. It involves a unique system that come off you might remember there's an internal iliac artery. The uterine artery comes off that. It basically surrounds that the uterus, and then you'll have arteries that go directly into it. Okay, and these arteries begin to actually spiral. They almost look like a corkscrew. And those spiral arteries, the one that go into spasm, and I'll go over it with you in class. And effectively, when a spasm is released, the spasm causes the layers to become unstable and cause them to separate. When the spasm is releases, the pressure head of blood basically causes what we call menstruation. So the spiral arteries are off the uterine arteries, which are off the internal iliac. And the breast itself, we cover it here too. The breast is mostly fatty tissue in an adult female. The glands are there, but they don't enlarge except during pregnancy and preparation for lactation. Nothing out of the ordinary. The big muscle they sit on is pectoralis major. Most people know that. When they do breast augmentation implants, depending on what they're trying to achieve cosmetically, they'll either put it under the muscle or over the muscle. I don't know enough about it to talk about it. That's there. So all that, you're going to see the cutaways that are there, but it's mostly fatty tissue. And again, there's a lot of glandular tissue, but the glandular tissue is undeveloped. That's there. Let's see. We already talked about, again, in the male reproductive, again, seminiferous tubule, sperm collected. That's where the sperm starts. It's collected by the epididymis, matures there, becomes effectively it goes from its immobile or non-motile MOTILE stage to its motile stage, and it basically is stored there until the time of ejaculation. And we store there for a pretty significant period of time. Again, cryptorchism is that part where we have the undescended testicle. You should remember that as well. And the whole idea of descending the testicle is to lower the temperature because it optimizes sperm production. And if I didn't mention it, I'll make sure I did. The blood testes barrier. Sperm don't form until puberty. Your body, your immune system doesn't recognize them as self. They're foreign. So this unique cell we call a sperm cell, when there's been trauma to that area, or if someone had to operate on the area, if they violate that barrier and the sperm are exposed in any way, shape, or form, and we see it more often with trauma than anything else. Okay, or maybe a poorly done, vasectomy. What happens is your body's immune system attack these foreign cells, and it's really a big problem. Yeah, it's somewhat analogous to the blood-brain barrier. So this is basically they are protected and they're kept within these tubular systems. And remember, this is a closed system, unlike the female and the male. And it's because of that reason. If it was an open system, the sperm would be attacked on their journey. If they somehow were released into an area where they're exposed to the immune system, here they are not. Okay, the only time sperm will get into this in physiology when they're exposed to immune is in the female's immune system. They have something called hostile mucus or attacked by white blood cells, potentially. So really what happens is you don't want your own white blood cells attacking the sperm for the male, of course. And really, there's a vast number of sperm, but they're so extraordinarily small microscopically that the vast majority of the ejaculate, there isn't a whole lot of it. It's like a half a teaspoon or so. Maybe there's several 100 million sperm, but the vast majority of the fluid is about 2/3 to 1/3 seminal fluid and 1/3 prostatic fluid. And we'll get into the prostate. I got to make the point because guys have to start knowing this right away because it starts depending on family history, maybe earlier. In the old days, you had to do a digital rectal exam to feel for enlargement, roughly starting at age 40. But now, not only that's still there, but now we have the magic of something called PSA. I'll explain what that is, called prostatic sensitive antigen. We use that to determine if there is prostate cancer and also to monitor its progress or the potential to form prostate cancer. Mm, I'm thinking I got everything done here. Yeah, baby. I think we're done. All right, we're done. Nice talking. If you have any specific questions, please feel free. We're going to, because some of you want to do this Monday. Bye.